Hi, my name is KatieHarden, and today I'm going to discuss the graduate medical education funding dilemma and some possible solutions. Prior to the Affordable Care Act, the Association of American Medical Colleges estimated that there was going to be a shortage of 45,000 physicians by the year 2020. With increased demand of health care following the Affordable Care Act, the Association of American Medical Colleges now estimates that there's going to be a shortage of 45,000 primary care physicians plus an additional 46,000 specialty care physicians, all by 2020. Medical education has fallen behind in meeting the needs and the increasing demand for healthcare in the United States. The Association of American Medical Colleges issued a statement on the physician workforce. It included a recommendation that United States medical schools increase enrollment by 30%. Now, medical schools are on track to meet that 30% goal actually by 2016, but residency training programs have only increased enrollment by 8% since 2002. There are over 5,700 hospitals in the United States. 1,200 of those approximately have graduate medical education training programs. Before we go any further, I want to explain a little bit about the training path of a physician. It'll help you understand a little bit more about what I'm talking about. First, they enroll in undergraduate college or university. They complete a 4-year degree. Many refer to this as pre-med. It usually is a Bachelor of Science in biology or similar degree. After pre-med, students complete a 4-year undergraduate medical education degree, or medical school as we tend to call it. This is when they get their MD or their DO. This is what makes them a doctor, a physician. Upon completion of medical school, doctors then can apply for graduate medical education slots or residency programs in a specialty of their choice. This is what trains them in that specialty: cardiology, orthopedics, family medicine, general surgery. These programs can range from 3 to 6 years depending on the specialty that they choose to train in. From there, physicians could also choose to complete fellowship programs. This allows them to subspecialize. So an orthopedic surgeon doing a fellowship on hand, or a general surgeon training in bariatric medicine. These programs could be 1 or 2 years. Now, for the purpose of today, we're focusing just on the graduate medical education programs. So graduate medical education programs, they do have the opportunity to obtain some funding. Their funding is done currently through the Centers for Medicare and Medicaid Services, or CMS. Now, Medicare was initially intended just to be a temporary funding solution while institutions identified ways to take over supporting the programs themselves. Unfortunately, the programs have become dependent upon CMS funding to support their entire program. They haven't identified alternative solutions. Funding was established in 1965, and the Consolidation Omnibus Budget Reconciliation Act, they established the methodology for determining payments to hospitals for the costs of approved GME programs. There are 2 sections of the CMS reimbursement for GME programs. There's direct graduate medical education, or DGME, and indirect medical education, IME. Now, DGME payments, they cover the costs of the resident and the faculty stipends and benefits, and overhead costs like office space. The GME programs also receive an additional payment for Medicare discharges to reflect the higher patient costs that are associated with teaching hospitals. The calculation of this additional payment is what we call the IME. Now, IME was created to acknowledge the fact that there were higher costs associated with running a teaching hospital, and it helped address the concerns that teaching hospitals had a more complex case mix, more uninsured patients. They provided services that are not necessarily well reimbursed, like trauma centers or transplants. It also helped compensate teaching hospitals for all of the additional diagnostic tests that residents order. Now, residents lack a lot of confidence in what they're doing because they are still in training, and so they do tend to, at times, order unnecessary tests that they can't turn around and bill the patients for. So the hospitals have to absorb those costs. IME helps cover those additional expenses for those hospitals. So this sounds like a great plan, right? So what's the problem? Well, like I said, Medicare funding was intended to only be a short-term solution, not a long-term solution. However, it's been in place for over 50 years now. Training a resident costs more than $100,000 a year per resident, and Medicare funding currently is at $9.5 billion annually. We've all been reading about it in our textbook. The United States deficit is growing at an alarming rate, and federal spending on healthcare is rapidly outpacing other sector spending. So in 2012, expenditures were 17.5% for healthcare of our U.S. gross domestic product. Healthcare expenditures were 17.5% of the United States gross domestic product. Now, look at 2014 expenditures. Here's where federal spending on healthcare tied with Social Security at 24%. Now look at future projections. The future projections of healthcare and Social Security spending show healthcare rapidly outgrows Social Security spending. In an effort to get a handle on healthcare spending, though, the federal government is looking into methods to significantly cut GME funding as a part of their deficit reduction plans. Without some kind of reform to the Medicare Trust Fund, it will be depleted by 2030. And all of this is while residency programs are trying to push to get additional residency funding. They want more slots to be paid for. They're trying to meet this shortage that they're experiencing with medical students graduating and not having enough residency slots to support them. Thus, our dilemma. Our dilemma to reform graduate medical education funding to ensure that healthcare services for the future of our society exist. With the passage of the Affordable Care Act, there's projected to be a significant increase in the amount of patients needing healthcare or needing health services as a result of finally being insured patients. That, coupled with the aging of our baby boomers, it's going to lead to a shortage, to an increase in the demand of physicians, resulting in a shortage, particularly in primary care. You know, cuts to GME funding is likely going to lead to an even larger gap in between that demand for healthcare and the supply of the physicians in the workforce. If GME funding is not done at the national level, the viability of residency programs is threatened. There have been a lot of recommendations proposed to Congress about options, solutions, proposals on how to fund graduate medical education programs without using CMS. All of those thus far have been declined. However, there are two options that are still being reviewed by Congress and being discussed amongst the medical education community. Currently, GME payments to teaching hospitals depend solely on the number of residents and the percent of patients with Medicare or Medicaid. Hospitals are rewarded for the quantity of residents and publicly funded patients, not for the quality of their educators or the graduates' ability to meet the workforce needs. All recommendations thus far agree on one thing, and that is that training programs must be held accountable for their performance. Now, I will say this. All the accrediting bodies for graduate medical education do have outcome measurements. They do have expectations. But all of the recommendations thus far say that funding should be tied to their outcomes as well, just like hospitals are being required to now. The first program is the Institute of Medicine's that they recommended. They published a report providing key recommendations on how to reform GME funding. Now, the IOM does recommend that Medicare remain the primary source of GME funding, while the total amount of funding should stay the same at the current level, but they do feel like it needs to be adjusted annually for inflation. Now, IOM suggests that the IME and DGME combined into one fund, but then separate them into two subsidiary funds. They first say the first one is the operational fund. This would maintain funds for the current and approved programs. The second portion subsidiary fund would be the Transformational Fund. The Transformational Fund will finance initiatives, research, demonstration projects, and other things. The IOM also suggests a recommendation to reform or to establish a uniform per resident amount that is geographically adjusted. Now, all of this creates a potential for transparency, for accountability, better program oversight, and evaluation. It also allows for a more equitable distribution of those GME funds. That's allowing for the PRA to be equivalent across institutions. So the program by IOM also proposes performance-based metrics for funding GME with expected outcomes. Now those outcomes are things like competency in the care coordination, clinical competencies, but also their outcome requirements would be increasing the number of physicians in the specialties and geographic locations where they are needed the most. It also would require expanding training in community-based settings and increased physician practices in rural settings as well as underserved urban settings. Lastly, the IOM says there is currently very limited comparable data among GME programs, and Medicare funding is strictly formula-driven without any accountability, and their recommendation is that this needs to change. So the problem with this program is it still puts the funding responsibility on CMS, and this is the part I don't like. See, CMS patients, the Medicare and the Medicaid patient population in a typical hospital could be 20, 30, 40% of their entire patient population. Why are we requiring CMS to fund medical education when they're only a portion of those patients? This is when another viable option is still on the table. This is the one that intrigues me the most because it's a very different structure than I've seen thus far. So this other option was proposed by a group of physicians. It was initially presented in 2014 at a very large conference through the Association of American Medical Colleges. It was then published last month in a very reputable medical education journal. So the group proposed an all-payer system for GME funding. This all-payer system would be managed and financed by Medicare Education Workforce Trust Fund. So the Medical Education Workforce Trust Fund. The Medical Education Workforce Trust Fund, or MEW, the government, the commercial, private entities, the self-pay individuals, they would all fund it. Their funding would flow through it to support GME. So revenues would be generated for this fund by assessing a 0.6% surcharge called an educational assessment, or EA, on all professional and facility fees charged to all government and non-government healthcare payers for services provided by physicians, hospitals, ambulatory centers, nursing facilities, things like that, as well as payers of other healthcare services, related services like prescription drugs, devices, and durable medical equipment. The 0.6% surcharge, that number was percentage was determined based upon 2012 data in which 0.6% was the approximate percentage of total national health expenditure spent on GME. Based upon 2013 data, all payers would have contributed $17.5 billion toward GME funding through the educational assessment. The EA fee would be collected on a per encounter basis using a billing code modifier, resulting in the primary source of revenue for the GME portion of the Medical Education Workforce Fund. Note the significant drop in Medicare spending. So providers and facilities would then receive an incremental educational incentive, or EI payment, from the MEW fund, also using a billing code modifier. This would help cover costs associated with supervising the learners and maintaining that learning environment. EI will be an additional 10% payment per clinical encounter for physicians involved in teaching. Hospitals or institutions would receive funding through the MEW fund, very similar manner to what the IME and the way it functions in their dollars. It would be proportionally similar in the amount too. EA and the EI would be variable and adjusted by a Med Ed Advisory Commission. So you notice I said that there was a GME portion of the MEW fund. That's because there's a second portion, and this is what I'm really interested about because this is a very unique proposal that I haven't seen thus far that I really think is a great concept that could truly impact the paths our physicians take, and I'll explain in a second. The second portion of the Medical Education Workforce Fund would be a tuition for service program designed to fund the majority of undergraduate medical education, medical schools. So to encourage physicians to practice in communities and specialties lacking access to physicians and healthcare, the Med Ed Advisory Commission would oversee the Tuition for Service program, and the Medical Education Workforce Fund would finance the entire cost of tuition and fees for up to 92,300 medical students. In return for the tuition remission, the physicians who participate in that program would provide service in their chosen specialty in a designated community of need after completion of residency. Now, this is just optional. This is by choice. So if after completion of residency, they choose that they'd really rather not go into practice for that designated amount of time in a community of need, they could instead pay it back similar to a loan at the current market rate. To cover the cost of the undergraduate medical education tuition, participating physician clinics, practices, and hospital employers, they would be charged the direct cost of the tuition for service fees. So only the hospitals willing to accept those physicians and to hire them would be the ones actually paying for them. I work for a hospital. I used to work in physician recruitment. I can tell you that this option is so much cheaper for a hospital than trying to pay all of the fees associated with recruiting physicians. So this all-payer funding, it really does appear to make the most sense. It diminishes the Medicare expenses by $6.2 billion. That's over 66%. Medicaid expenses would decrease by $1.2 billion, or 31%. Plus, it would create a surplus of $2 billion. That $2 billion every year, that could facilitate so much needed reinvestment into GME without increasing or without decreasing the funding to existing programs and what they're receiving. It would also add that undergraduate medical education tuition for service program option. This would eliminate education debt for physicians in hopes that many of them would be more willing to go into primary care, but also that communities in need of primary care and specialty care trained physicians would finally have greater access to the qualified physicians and a better chance for the retention of those physicians long term. Medical education would no longer be a factor into the physician's education decision regarding what specialty they go into or where they choose to practice. The extra revenue, it could fund new residency positions. This would encourage the increase in the number of GME slots available. This would finally meet that need that we've talked about, the gap that's growing between how many students are finishing medical school and how many residency slots are available. Lastly, funding of GME and undergraduate medical education, it would be transparent and directly linked to the outcomes produced by the teaching faculty and facilities. Everyone benefits in this reform structure. I just have a few concerns. If hospitals and facilities have to pay into this fund, well, doesn't that mean our costs as consumers, aren't our costs going to go up? Insurance carriers, aren't they going to drive up the cost of their premiums to cover the costs that they are having to pay into this fund? Same thing with pharmaceutical companies. If they're having to pay a fee into this fund, Are our drug costs going to increase more than they already are? So many of them are astronomical and out of control. I'm a firm believer that CMS should not bear the weight of funding all graduate medical education expenses, as Medicare and Medicaid patients are only a portion of the patients that consume healthcare expenses for a facility. But if this is going to drive additional spending by consumers on healthcare, it may also completely defeat the purpose, won't it? This is going to impact the economy in a worse way than CMS funding predicts. You know, I think additional research needs to go into this project. This reform method, it seems to make the most sense. It pushes for further transparency and accountability, but it also drives physicians to practice in the specialties and the locations where our country needs them the most. I just think a greater financial analysis needs to occur first. I'm anxious to see what happens and what is decided about the funding of graduate medical education. See, I work for a hospital. My job is medical education. I coordinate medical students. What is decided about this will directly impact what I do and how I do what I do for my job. But I'm also a consumer, and what is decided will impact me just as much as it will impact you. We either experience a shortage of physicians, or we run the risk of all of our healthcare expenses as consumers climbing, impacting our healthcare expenditure problem even more than it currently is. I just hope whatever happens that it is for the positive. I hope that we find a good balance between meeting our healthcare needs by also decreasing our healthcare expenditures. I don't know about you, but I plan on staying informed. I have to. My job depends upon it. But our future as consumers also depends upon it. Stay informed, get educated, know what's going to happen, and be prepared for it. Thank you.